We are live now. With all your permission, I will be starting this session.
Yes, you can. Can you hear me?
Yes,
Yeah.
sir, you are clearly audible.
Okay, fine.
Just give me a moment. Good evening, everyone present here. I welcome all the participant doctors on today's panel discussion session. And for today's panel discussion, we have the topic hypertension in CKD. And before starting this session, let me tell you overview of the topic. Hypertension or high blood pressure commonly coexist with chronic kidney disease, that is CKD, and significantly impact its progressive and outcomes. Managing hypertension in CKD, it is a crucial to slow the decline in the kidney function and reduce the risk of cardiovascular complication. For this session, we have the moderator for today's session, Dr. Kunal Pai, sir. Sir is a consultant pediatric intensivist at Holy Spirit Hospital at Mumbai. I would request sir to come and hand over this session to him. Sir, kindly come forward and introduce both the panelists for today's session. Over to you, sir.
Yes, thank you for us. So, very good evening to everyone who is attending this talk. And today we are very lucky because we have two esteemed speakers with us. And today that we're talking about hypertension in CKD, we have a combination of a nephrologist as well as an interventional cardiologist with us. So we'll be understanding both the aspects of hypertension. And first speaker will be Dr. Pratik Tripathi, sir. He's the head of nephrology at the department at Multi-Speciality Fortis Escorts Hospital in Jaipur. And our second speaker will be Dr. Ramamurthy Binji, sir. He's an interventional cardiologist at Binji's Heart Care and Fertility Center. So I would request the speakers to now please begin the talk. Thank you.
Thank you, Dr. Kunal. Thank you very much. I think, Pratik, are you going to talk or should I go ahead? I think as it was made out, it was rather than a more of a slide discussion, instead of slide discussion, more of an panel.
Yeah, it's supposed to be a so-called panel discussion.
That's what
I can I would start with just give a small talk and then you can take over.
Please go ahead.
So the topic is hypertension in chronic kidney disease. So we should be looking at these two words, hypertension and chronic kidney disease. So what does one understand by hypertension? So hypertension has got a definite definition, and it's basically sustained blood pressures measured. The measurement where you are measuring is important, whether it's in the so-called clinic with the so-called office blood pressure, where it is sustained more than 140 systolic or more than 90 systolic, or number two, home blood pressure monitoring, where it's if the systolic is more than 135 and the diastolic is more than 85, or there's something known as ambulatory blood pressure monitoring, where the mean blood pressures are found to be the systolic blood pressure is more than 130 and the diastolic blood pressure is more than 80. So, I mean, this, if it is sustained and measured again and again, and you find that it stays that way, you call it hypertension. Now, let's come to the other word, CKD, which is the short for chronic kidney disease. Now, chronic kidney disease has a definite definition. It is it's a syndromic diagnosis per se, because there are so many underlying causes. But this is a renal kidney disease, which is irreversible and progressive. And we tend to measure the so-called estimated GFR, and we define someone as having chronic kidney disease when we find there are abnormalities in the estimated GFR, or there are abnormalities in the anatomy of the kidney, or abnormalities in the functions of the kidney, including abnormalities in the urine, examination which lasts more than 3 months. So if that is the case for someone, then one can make the assumption that this person has chronic kidney disease, and by definition it's supposed to last, it's supposed to be an irreversible phenomena, and in fact it's supposed to be a progressive phenomena. And now let us understand what is the burden of disease. Hypertension per se is a very common phenomena in mankind and amongst humans. And I, being a nephrologist, I tend to see a small segment of people who have renal disease. And sir, as a cardiologist, maybe sees more people, even the general population who don't have heart disease. If they have hypertension, they would go to the cardiologist, because I mean, for a long time, this was the preserve of the cardiologist. And so now, with the recognition that the kidney plays a very important role in hypertension, and with the recognition that most CKD patients tend to have high blood pressures. In fact, more than 90% of these CKD patients have high blood pressure, and difficult blood pressure, so-called resistant hypertension and refractory hypertension. These are terminologies that are used by clinicians. That you find them amongst CKD patients very often. So hypertension is very common, tends to increase with age, and in fact, more if some people who are aged 70 or more, they more than 50% would be hypertensive as per the criteria. And as far as CKD patients are concerned, CKD is quite common. Because most of it's almost like an ice. It's almost like iceberg. Part of it is submerged in the water, and only a small tip is there on the surface. The submerged part are those people with estimated GFRs, which are not too bad, but they still have CKD as per the criteria. And in fact, estimates are up to 10% of the human population would be having CKD if we follow the strict criteria for CKD. And 90% of these patients would have hypertension at some point. In fact, by the time they reach dialysis, more than 90% have hypertension and difficult to control hypertension. Why would the CKD patients why would they have hypertension in the first place? Hypertension, the contribution, systolic blood pressure as well as diastolic blood pressure. The diastolic blood pressure is presumed to be due to the peripheral vascular resistance, and the systolic blood pressure is more dependent on the cardiac output per se. In CKD patients, CKD is a very special situation. A lot of things happen. One thing that happens is the number of nephrons in the kidney declines. And with the decline in the number of nephrons, the functions, very important functions of the kidneys are getting affected. Amongst them is the proper maintenance of the internal metabolic milieu. So the salt retention tends to occur. Sodium chloride gets retained. It's not excreted as it should be. And with that, fluid retention also tends to occur. And metabolic milieu gets disturbed, and you have accumulation of these uremic, the uremic toxins. So in the blood vessels, in the walls of the blood vessels, where the vascular resistance, which determine the vascular resistance, nitrous oxide gets affected. The endothelial damage also starts taking place. There is widespread, in fact, generalized endothelial dysfunction, and also the sympathetic autonomic nervous system tends to come into play. So you have abnormal efferent impulses from the kidney to the brain, and you have vasoconstriction taking place throughout the body. And because intrarenal within the kidneys, especially in the tubules and the interstitium, because of the fibrosis that occurs invariably in chronic kidney disease, you have distortion of the blood vessels which supply the parenchyma, and you have production of they have so-called perception of a ischemic state within the renal parenchyma. So more renin production takes place. The ACE axis gets activated. More aldosterone also gets produced. Angiotensin 2 levels tend to go up. So there are so many multiple factors coming into play all at the same time in CKD patients, and you have hypertension. In fact, not only just simple hypertension, you have things like resistant hypertension and refractory hypertension, where the number of drugs keeps on piling, and still you don't see any effect coming into play. Now, hypertension in CKD tends to be very important. As a matter of fact, we as nephrologists, we think that treatment of hypertension is probably the cornerstone of treatment of CKD, because I mean, at the end of the day, CKD is not a curable disease at all. So as a nephrologist, all you are left with is to slow the progression of disease. And how do you go about it? How do you slow the progression of disease? To slow the progression of disease, it seems control of blood pressure is most important. And why would you say control of blood pressure is most important? You will understand, because when I tell you the physiology is that the blood 25% of the cardiac output is going into the kidneys. And if you look at the anatomy within the kidney, you have the afferent arteriole, which breaks into glomeruli, which are capillaries, just single cell thick, very delicate. And then you have the efferent arteriole. Now, blood pressure, once it starts going up, the full pressure of it would cause intraglomerular hypertension. It would damage those glomeruli, the capillaries in the glomeruli, and it would cause them to die. I mean, it would destroy the glomeruli. So, in other words, if the blood pressure is not under control, the attrition rate is accelerated, and you have more with time, more damaged nephrons. And obviously, because you are a person with CKD has limited number of nephrons, and they are getting destroyed. This is one reason why they are getting destroyed. And so blood pressure control is very important. The autoregulation in CKD gets affected. A normal person can in fact control the intraglomerular pressure remains the same between a mean arterial pressure of 80 to 160. That's a huge gap. I mean, how does the body do it? The tubuloglomerular reflex and the myogenic reflex, and there are other things which come into play. In CKD, all these things are limited. So at certain point, the full force of blood pressure is transmitted to the glomeruli, and the damage occurs. So the treatment of hypertension is the cornerstone of treatment of CKD. Once someone has CKD, blood pressure control is the most important. Other things are there, but if you have not controlled the blood pressure, you have not done 90% of your job. The rest is actually 10% of your job. This is 90% of your job. This was a very short, succinct summary. I'll tell Sir to take over and give his views.
I think you have done a wonderful summarization. The fact that the blood pressure is so rampant and so prevalent in the society, and how kidney disease is also equally important, 10 to 15% of the population is affected, and how one leads to the other. Hypertension leads to the kidney problem leads to the perpetuation of hypertension. And you also brought out the issue of a diagnosis. The diagnosis now for the last 10, 15 years, a lot of noise is being made that we are coming to the even without the kidney disease also, the criteria are coming lower and lower and lower and lower. Now everybody wants to accept it something like 120/80, maybe 130/80. So as you know, what is your impression about the diagnostic figures and then the target figures that you have to take up in the management of renal failure? Can you just tell a little bit about these things?
Yeah, in in CKD, as I mentioned, autoregulation is very important. So blood pressure control is also very important, and there have been various studies, surveys, which actually said that previously we were quite happy if the blood pressure was 140, less than 140 by 90. Okay, that's fine, that's good. But the recent surveys suggested that things are not good even if the blood pressure is 130 by 80. The people would still be prone to stroke and things like that, cardiovascular morbidity, despite the so-called normal blood pressures. So, especially in CKD, we have a situation. Our class we stratify CKD on the basis of estimated GFR, and also we add another point to this. We add the degree of proteinuria. So the more the proteinuria and the lesser the estimated GFR, the worse the prognosis as far as the progression is concerned, because the patient is obviously nearer dialysis or requiring dialysis, number one. Number two, there is a huge connect in CKD with cardiovascular morbidity. CKD patients would have 50% of dialysis dependent CKD patients have heart failure. They are prone to coronary artery disease as well, and they have stroke as well. So it has been seen that with worsening estimated GFR and with increasing degree of proteinuria, cardiovascular disease morbidity burden tends to increase. So blood pressure control, since the surveys in the so-called general population also suggested that more stringent blood pressures are required. So in CKD patients, we have targets depending on the estimated GFR and the proteinuria level, and whether the person is diabetic or non-diabetic. So diabetic patients have a worse prognosis at any stage of chronic kidney disease. So they have more burden of cardiovascular disease than someone, for example, with the ADPKD, the autosomal dominant polycystic kidney disease, with the same who is lying in the same level stage of CKD. So it's as far as CKD stage 1 to 3 are concerned, we have blood pressures. We like to keep it very stringent, less than 120 by 70 if possible, if tolerated. And especially if this person is having proteinuria of more than 300 milligrams, albuminuria of more than 300 milligrams in 24 hours, our targets are 120 by 70. As far as stage 4 and 5 are concerned, and where the proteinuria levels are much higher, these patients actually 4 and 5 are very close to requiring dialysis. So they're apparently, and because they have these changes in their vasculature as well, and sometimes, for example, stage 5, the person is already on dialysis, and the gentleman obviously requires a fistula. And when he has a fistula, an arteriovenous fistula, we require a certain pressure head to keep the fistula patent, because the dialysis process itself is dependent on the patency and the efficacy of the fistula. There, a blood pressure of 120 by 70 may lead to the disastrous consequence of a thrombosis of the fistula. So there also they don't tend to tolerate these kinds of blood pressures very well. because probably they have been used to high blood pressures for such a long time. So we tend to have a target of 140/90 or less in these patients. So these are the targets as far as CKD patients are concerned. Generally, the rule of the thumb is that if proteinuria is increasing, but CKD level is not very high, that is, the estimated GFR is not bad, then you try to preserve the renal function as much as possible. And to do so, you try to be as stringent with the blood pressure control as possible. And then you are looking at targets of 120/70. As also the 120/70, this kind of blood pressure also applies to autosomal dominant polycystic kidney disease patients as well, where you might be aware that there are multiple cysts, and the kidneys are enlarged, and there is distortion and destruction of the interstitium, uh, and with distortion of the blood vessels. And ACE, we tend to use a lot of ACE. In fact, ACE inhibitors are the drug of choice over there. So in the initial stage where the renal functions are not really bad, uh, uh, we tend to have very stringent control of blood pressures in these patients, despite the fact that their proteinuria levels may not be high, because this is a tubulointerstitial disease. And if you examine their urine, the proteinuria levels are not that high. I hope I answered
I think that is
your
true. You have
question.
brought out very nicely. In fact, as you said in the starting remark itself, kidney disease as well as the heart disease are really more like brothers. We are concerned once the patient is labeled as a CKD, he is considered as an equivalent of one risk factor, just like hypertension, diabetes, cholesterol, and the like. So we would like to be interested equally to see that it doesn't progress and all that. And you have brought out all the pathophysiological mechanisms that are responsible for hypertension. In fact, hypertension itself is basically a non-homogeneous hemodynamic entity. As the disease progression happens, you do get so many other factors into consideration. You brought
Yes.
this issue, and particularly the lot of noise is being raised after the sprinter trial, that
Yes.
blood pressure should be brought to 120/70. It is impossible. I don't know, in our day-to-day practice, majority of the patients hardly come down below 140/90. 50% of the patient, they do remain high up, and clinical judgment always says that you should give the medication in such a way it doesn't create any too much of a side effects. And
Yes.
diabetic patients are more for postural hypertension also.
Yes.
We should be really careful not to push too much of medications like that. Yes, the principles are the same, but the sometimes we may have to become more individualized as far as the medication is concerned. So, what is your feeling now? As I understood, I think my other colleague also knows it, that the renal failure is a sort of a spectrum, starting with the renal dysfunction to the level of mild renal dysfunction, maybe moderate to severe, dialysis dependent, non-dialysis dependent, going on for a transplant program. So many things are there. And naturally, the choice of medication may have to vary from one level to the other level also. And we have to be careful about particular some of the drugs which may produce some of the indirect effects on both the heart and the kidney. What are your comments about this?
Well, as far as recommendations go, KDIGO guidelines, the latest one we had in 2021, KDIGO guidelines, they have suggested that for almost all chronic kidney disease patients, the recommendation should be that when you are starting medications, in an ACE inhibitor or an ARB should be the drug of choice as a starting drug. Uh, I understand that can be difficult. It was for most nephrologists as well, especially Indian nephrologists. That was something that was kind of difficult to swallow. I mean, because our patients, we understand what we are talking about when we say ACE inhibitors and ARBs, and especially when you are giving these drugs to patients who have chronic kidney disease. So chronic kidney disease, the creatinine is already high, and they are already prone to hyperkalemia. And now the recommendation is that you give a drug which can, in fact, increase the creatinine level, number one. Number two, increase the potassium as well and potentially cause death. So that was difficult. But then, I mean, as a physician, because these drugs are your so-called, these are your guns or whatever. I mean, you fight with them, and you should know how to use them. As simple as that. So the the idea is that if you have to prevent the attrition, the inexorable attrition of nephrons that is taking place, you have to preserve the glomeruli, and to preserve the glomeruli, you have to control the intraglomerular pressure. And apparently, ACE inhibitors and ARBs are the only drugs which do that with a lot of efficacy. So, what is the flip side? The flip side is if you relax, when you give an ACE inhibitor or an ARB, the efferent arteriole is relaxed, and the efferent arteriole is relaxed. So what happens? The blood flowing through the efferent arteriole enters the glomeruli and easily goes out through the efferent arteriole. The intraglomerular pressure declines. So when the nephrons are getting reduced in number, the natural tendency of the body, of the human body, is to cause uh, constriction of the efferent arteriole to maintain the increase the intraglomerular pressure, so that the filtration pressure is maintained, and the glomeruli, the number of glomeruli, since they are reduced in number now, they can increase their filtration rate. So the single nephron GFR increases when you cause the efferent arteriole to constrict. So everything looks nice on paper at that time, because the creatinine is not running away, it's not going up, and things are looking fine, and everybody is happy. But what is actually going on in the body is that the intraglomerular pressure is causing, the high intraglomerular pressure is causing these nephrons to die more quickly. So you really don't really have a choice, as far as logic is concerned, that you have to use an ARB or an ACE inhibitor to prevent this sort of thing from happening. And we did realize that the so-called initial jump in creatinine is actually a hemodynamic effect, because there is no actual destruction of nephrons taking place to cause the creatinine to go up. What has simply happened is that the so-called single nephron GFR, which was elevated because of this particular adaptation that the body, or maladaptation that the body had done, has now come down, and so the creatinine has gone up. In fact, it was shown that people who are exhibiting this phenomena where the creatinine is going up are actually the persons who are getting the maximum benefit, because they were the ones who were having hyperfiltration, and simply giving an ACE inhibitor has curtailed that hyperfiltration and brought it down to the actual level of what it should have been. There is a caveat over here. We make the assumption that the rise in creatinine should not be more than 30% over the next 2 weeks. So if it is more than 30%, then there is something wrong. What is wrong? It could be that the person has bilateral renal artery stenosis, or it could be that the person is actually dehydrated, and you have not been careful giving the drug, or the person has taken some extra other drug, for example a painkiller like ibuprofen along with an ACE inhibitor, to cause the jump in the creatinine beyond 30%. So that is the caveat. If it is the rise in more than 30%, you stop ACE inhibitor immediately, and you try to figure out what has happened. And once you are satisfied that it's not the ACE inhibitor which has caused it, and it was something which was temporary and transient, like dehydration, for example, then you reintroduce it and try to keep it for as long as possible. Of course, potassium will also come into play here. A lot of these patients have tubular dysfunction in addition to glomerular disease as well, because tubulointerstitial fibrosis is also going on at the same time as the glomerular sclerosis is taking place. The glomerular damage is taking place, and we know that tubules are handling the potassium. So um, even with where the creatinine clearance is not really too bad, maybe more than 30 ml per minute, even there potassium may be high because of type 4 renal tubular acidosis, which happens quite frequently in diabetic patients. For example, they have, even when you are not using an ACE inhibitor, they would be prone to keeping a high potassium levels because they have tubular dysfunction with particular damage taking place at the distal tubule. So and we know that these diabetics are the people who are also having a large degree of proteinuria, and we know that ACE inhibitors, by reducing intraglomerular pressures and by reducing single nephron GFR, are also the same drugs which are reducing the degree of proteinuria and helping in this disease. Proteinuria is very important here. Proteinuria, why are we emphasizing so much on proteinuria? The reason is the protein which is leaking into the tubule goes into the tubule and causes a lot of destruction in the tubule and causes accelerated attrition of nephrons. This phenomena is kind of slow in people who have even, for example, chronic interstitial nephritis, which is predominantly a tubulointerstitial disease. But the progression is much slower in these patients because they are not leaking that amount of protein. The moment these patients, chronic interstitial nephritis patients, the moment they develop something known as secondary focal segmental glomerulosclerosis, secondary FSGS, and they start having a lot of leakage of protein into the tubules, everything goes out of control. There's not accelerated damage to the tubules occur, and more damage, more rapid progression of disease occurs. So ACE inhibitors are also working there as well, reducing the proteinuria. But as I said, potassium is also going up. So what are you supposed to do? You have to monitor. That is the only thing that you can do. In the Indian context, that can be very difficult. Patients would not turn up for months altogether. You give a drug and they would, in fact, you will find some of your patients coming to after 2 years, continuing with the drug with the prescription which was written 2 years ago. And you start telling yourself, my goodness, I mean, they are very brave people. I mean, how the hell are they supposed to do that? With a creatinine which is 9 now, which was 2 at that time. Whatever. They would be continuing with metformin, they would be continuing with ACE inhibitors, and they would never monitor, they would never go to the doctor. So it's a huge challenge as far as the Indian nephrologists and doctors in general are concerned. So you have to monitor potassium. You cannot let it go above maybe 5, which is admissible. And you have to, take care of the diet and maybe add drugs which take care of the potassium, reduce potassium. Maybe give drugs. Sometimes, CKD patients, they do require diuretics. And then we have the option of giving them thiazide as long as the creatinine clearance is fine. Thiazides are useful because they do cause a lot of caliuresis, or we can use even furosemide is not bad. You can use these diuretics, you can use potassium binders, and to take care of the potassium. Um, so ACE inhibitors, ARBs in most people. Now, when the creatinine really goes down and the person is at the so-called brink of requiring dialysis, at that time when the person comes to you with a creatinine of maybe 5, he is still not requiring dialysis, but very close to it, and the potassium is fine at that time, then you have to ask yourself, what am I supposed to do now? Should I stop it? If I stop it, so there was a trial, which stop ACE trial, where they, actually stopped it. So they found that where the ACE inhibitors were stopped, those patients, these trials were carried out in North America. So obviously, a lot of good monitoring took place. So when the trial, ACE inhibitors were stopped, these people were more prone to developing cardiovascular events like stroke and other things, though the blood pressure was fine. Uh, and heart failure, the ACE inhibitors we know are the bedrock of treatment as far as heart failure are concerned, and heart failure is a particular phenomena occurring very commonly in CKD patients. So ACE inhibitors come into play there as well. So it was seen that maybe it may make sense to continue with ACE inhibitors if you can. But if you want to start ACE inhibitors when somebody's creatinine is already 5, maybe it will not make sense, because you will push him into requiring dialysis. Because as I said, this creatinine 5 is a result of hyperfiltration. A single nephron GFR, high single nephron GFR. The moment you give ACE inhibitor, the efferent arteriole relaxes, the GFR, the intraglomerular pressure goes down, and the GFR goes down, and the creatinine goes up, and you actually may push this patient over the ledge into requiring dialysis. So you have to be, this is a clinical judgment that you have to make. In situations where the monitoring is not possible, where the patient is not ready for a fistula, maybe ACE inhibitors may be discontinued. So ideally, if someone has a creatinine of 5 or 6, is on the verge of requiring dialysis, as a nephrologist, you tell him you get a fistula right away, because you don't know when you're going to be on dialysis. A common cold will precipitate dialysis. Just because if you have a diarrhea, you will enter into dialysis. Simple diarrhea. If you take a single dose tablet of painkiller, you will get into dialysis. So it makes a lot of sense that you have a fistula. Most people, like 80% of your patients, will start dilly-dallying, and they will say no at the very first instance. So it's only 20% or even less than that who actually agree and say, yes, I'll go ahead with the fistula. No one says yes. They ring up a lot of other doctors and try to figure out if they can wriggle out of this situation. So as I said, ACE inhibitors or ARBs. On top of that, because CKD patients are very special patients, and we have situations known as resistant hypertension, where the blood pressure is not even under control with 3 drugs, or refractory hypertensions, where even 5 drugs are not working. So you have to use drugs like clonidine, which other people probably never use. Things like nifedipine, we use 90 milligrams of nifedipine in 24 hours. Same person having our, clonidine 600 micrograms, nifedipine 90 milligrams, prazosin up to 20 milligrams maximum dose. Beta blockers like metoprolol almost 200 milligrams if the heart rate is allowing, and if the heart is not really too bad and you are not causing decompensation of the heart failure, you can start put on the beta blocker, piling it up slowly things. So we tend to use a lot of antihypertensives, probably more than anyone else, and so a lot of other drugs also come into play apart over and above ACE inhibitors. As far as renal transplant patients are concerned, for some reason, the targets are also somewhat different. We need a blood pressure of 130 by 80, not more than that, and not less than that. And here, dihydropyridine, the calcium channel blockers are the drug of choice, first, number 1, followed by plus minus ACE inhibitor or ARB, if you can actually give it. because we are using drugs like tacrolimus, which cause vasoconstriction, intrarenal vasoconstriction, and toxicity of tacrolimus may be compounded if you are using an ACE inhibitor at the same time. So when everything is fine, when the blood pressures, the tacrolimus levels are at their doses are at their lowest, maybe after the end of 6 months or 1 year, where the possibility of tacrolimus toxicity are the least, at that point we start thinking of giving an ACE inhibitor, because we know ACE inhibitors are going to preserve the nephrons in the graft, and of course give additional protection to the heart and the brain, and to the peripheral vasculature as well. So ACE inhibitors, ARBs at that point,
Thank
not before that.
Tripathi has been very, very elaborate in choosing a medication, particularly the ACE inhibitors and ARB drugs are concerned. They are the drugs of choice, whatever the stage we are treating them. And we have an evidence to say that there is a decrease in the mortality and morbidity. And more than that, from the nephrology point of view, there is a decrease in the deterioration of the renal function. That's most important. For example, patient who is being managed medically, the time for dialysis is extended, time for transplant is extended, and like this, there is a lot of benefits. But there are some, from the cardiology perspective, there are 2, 3 points I would like to mention. We have seen many a times young patients in whom we have put up the ACE inhibitors, ARB drugs. Their creatinine is somewhere jumping around between 2 to 3 mg/cent. We become little alert in renovascular hypertension in these cases. What are your comments, sir?
Yes, of course. I mean, the protocol is, if the rise in creatinine from baseline is more than 30% after, if you have introduced an ACE inhibitor, the first thing that you have to do is rule out the possibility of renal artery stenosis. I mean, especially bilateral renal artery stenosis. Though now, apparently the literature suggests that once you even established bilateral renal artery stenosis, where you're not going to do a PTRA, and you want to preserve the renal functions, in a very cautious way, you can use an ACE inhibitor even in these patients to preserve whatever is left of the kidneys. Of course, I mean, renal artery stenosis has to be kept in mind all the time. We also, yes, sir, please.
I concur with you, Tripathi. Very nice of you. You brought that issue that we should be keeping in mind. And
Yes.
the world is moving in a little different direction. We used to be little, irritated with our fingers all the time to put a balloon or a stent in a renovascular hypertension. But one of the editorial which I saw, they say renovascular hypertension, if you're trying to do something for a renal artery, it is a fundamental principle is to protect the renal parenchyma from ischemic damage rather than really hypertension. In fact, many of the trials have shown hardly about 25% will be cured. The remaining 70% will be continuing to take medication either in a limited or in the same manner. So it doesn't really look sounding, but there are many other things that are coming like renal sympathectomy, then carotid sympathectomy and the things. I think is a very bright field which we are going to see as far as hypertension management is concerned. As a cardiologist, often I use beta blockers quite frequently because among the antihypertensive drugs apart from the ACE inhibitors, beta blockers are the one group which have shown a definite reduction in the mortality and ischemic events. This is probably related to more of an antiarrhythmic effect of these drugs. And of course, one has to choose a beta blocker which is not dependent on the kidney route. It is getting metabolized in the liver or something like that, something like metoprolol, which are the better drugs. And now the resistant hypertension you brought out, that is true. Many of the patients, they do not come out controlled with all the 3 or 4 combinations. There is one recent report which has suggested that adding in a spironolactone at the last
Yes,
patient
yes,
sometimes
yes,
helpful in some of these patients. I think they
absolutely.
should be able to guide us more how frequently we should do the potassium in these patients and how
Yes,
frequently we should do the GFR and look at the creatinine values quite frequently.
yes.
I
See,
think, yes, sir. Go ahead, sir.
yes,
Hmm.
yes. Spironolactone is a very interesting molecule. I mean, we tend to use a lot of it, and now we have Finrenone as well, non-steroidal mineralocorticoid receptor antagonist. Apparently, with a better reputation as far as hyperkalemia is concerned. So, uh, but that is basically for heart failure and for other things. But as far as blood pressure control is concerned, as per our protocol in resistant hypertension, once you encounter what is known as resistant hypertension, where you have used an ACE inhibitor and you have maximum dose plus a thiazide plus calcium channel blocker, and still your target is not been achieved, there at that point you add a spironolactone or a mineralocorticoid receptor antagonist. You can use aplerenone as well. So 25 milligram of spironolactone would be equal to 50 milligrams of aplerenone. And
There are,
well,
can I add
um,
a small interference
you
here?
know,
I have seen the prescription, a lot of nephrologists, the way they have used the alpha blockers, like Minipress XL and all that, in the second or the third group of medication. Like, what are your comments, sir? I think they
comments.
as that many of the nephrologists they do add
Yes,
alpha blockers once they have been exhausted with ACE inhibitors and the beta blockers and diuretics. What are your comments,
yes.
sir?
Yeah, we are supposed to be using ACE inhibitors as first line or ARB as first line. We tend to complement this, add a dihydropyrid, DHP calcium channel blocker to this. If still blood pressure is not under control, then we add a beta blocker as well. And of course, if the fluid situation, you have to assess the volume of the patient, and if you find definite edema, then obviously one has to give a diuretic. So at this point, if the blood pressure is under control, well and good. But if it is not under control, then we have other options as well. We use prazosin quite frequently, and since we have the sustained release form, it tends to do pretty well. I mean, people generally don't tend to have orthostatic hypotension as it is written in the textbooks. We also tend to use a lot of clonidine. Uh, though clonidine and beta blockers don't go very well together, because I mean the synergism is not there. But you can the clonidine tends to go pretty well with nifedipine, for example. And then now we also tend to use a lot of hydralazine with isosorbide dinitrate, the so-called isolazine. This combination, it tends to work pretty well, especially those who have systolic LV dysfunction. And since it has isosorbide dinitrate, so even if the person has a coronary issue, even that is taken care of. And we tend to combine isolazine with beta blockers more often than with anything else, because you have to take care of the heart rate. If you are using something like hydralazine, which can cause reflex tachycardia, then you have to take care of the heart rate, and a beta blocker goes very well with isolazine. Uh,
I
and
think
when oh,
Tripathi, you have
yes,
taken as a very much. What for us? Are we going correctly, or you want me to give about 5 minutes time for the questions and answer session from the
Sir,
audience?
I have you are
They would
covering a
have coming.
topic really well, sir.
Sorry,
But
Tripathi, I
we
am
have
trying
some
to
questions in the
hold
chat
you
box, sir.
back.
You can check it. Sir, we have some question from the participant doctors on the chat box. You
Yeah.
can take this question. First
I
question
know
is
that.
from Dr. Ashwin.
Tripathi, thank you very much. You have taken us really down the line.
Yes, sir.
How important a kidney disease is in a heart disease patient, hypertension management, pathophysiological mechanisms, prevalence that is existing, and the definition criteria that are changing. And you have also made us very clear what the drugs we are choosing and the how the ACE inhibitors and ARB drugs are the first lines, and additional drugs can be taken more on an individual basis. I really appreciate your concern and you have
Thanks.
been very clear cut. Any
Thank you.
questions from the audience so that we have already nearing 8 o'clock? There's a 1
Yes,
hour.
sir. I
Yeah.
can see, sir, there are some questions from the participant doctors. I
Right.
can see Dr. Agarwal is asking what are your point of view on BP treatment after kidney transplantation?
Yes.
Yeah, as I have already mentioned that we have a target of less than or equal to 130 by 80. We tend to use dihydropyridine calcium channel blockers as a first line drug, amlodipine or nifedipine. And if on top of that, if you have to add something, we tend to add a beta blocker, and you have all those other drugs. Obviously, when you're giving a drug in the transplant setting, you have to make sure that the drug is not interfering with the metabolism of drugs like tacrolimus. If you are using a calcineurin inhibitor like tacrolimus or cyclosporin, any drug that you give, you have to go through the whole list as to whether it's interacting with this or not. For example, amlodipine or nifedipine would tend to increase the level of tacrolimus somewhat. So you have to be prepared for that small rise in the level of tacrolimus. Sometimes it helps. For example, in fact, we deliberately use diltiazem in these patients because the dose of tacrolimus can be reduced by as much as 30% by using full dose diltiazem. So because diltiazem tends to interfere with the metabolism of tacrolimus. So
Yes.
we purposely use diltiazem in some of these patients.
Uh,
As
uh,
I said, ACE inhibitors, generally we tend to give when everything is stable and the lowest possible tacrolimus dose is in place and the graft function is fine, and we are not too worried about a rise in creatinine level or any risk of acute tubular necrosis, because one should be aware that if you are using an ACE inhibitor, the kidney would be exposed to the possibility of ischemic damage if and when that sort of assault takes place. For example, somebody on ACE inhibitors gets dehydrated because of diarrhea, there would be acute kidney injury. So we tell these people to have a so-called sick day off. So if someone is unwell, it would be best that they switch off ACE inhibitors at that time, so that they can take something bland as far as the kidneys are concerned, like amlodipine during that time, to take care of their blood pressures. Obviously, the blood pressures are being monitored more frequently during this time, and when that illness has passed off, then you reintroduce ACE inhibitors. So we tend to do that quite frequently. We tend to do that with this as with dapagliflozin as well. Dapagliflozin also has antihypertensive effect. As a matter of fact, we have started using DAPA in place, especially in you have things like entities like IgA nephropathy. We are giving ACE inhibitors. ACE inhibitors are totally indicated in IgA nephropathy. If you can give them, you have to give them. And over and above that, after you have taken care, because total blockade is inhibition, then you add DAPA. DAPA.
yes.
And yes,
But
sir.
I just I can make a small comment here.
Yes, yes.
As a cardiologist, sometimes we are called for when an uncontrolled blood pressure goes on manifesting post-transplant, and then we may have to give you some renal artery, whatever the grafted kidney is there, from there any stenosis is available. And
Yes, exactly. Yes, yes. That thankfully is a very rare phenomenon.
that's where we come together, is it not?
Yes, 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 of course, of course. I mean, yeah, I very recently one of my patients had this particular problem. Yes, so we did take care of this, and our cardiologist took care of it. Thankfully, it went quite well. So, but anyway, thankfully it's a quite a rare phenomenon. One has to keep that in mind all the time.
Yes.
Yes.
Faraz, any other comments or
Yes,
questions?
sir. Thank you so much, sir. I hope that the point of view of the Dr. Agarwal has been cleared as both of you has really explained really well on this. Sir, moving forward, there is one case study from Dr. Vaibhav. He is asking, a 60-year-old man with CKD, diabetes, and hypertension is on treatment with maximum dose of ACE inhibitor, but both his BP and proteinuria are still not at therapeutic targets. Which would be the best choice for antihypertensive therapy? Additional proteinuria reduction is a goal, and what same BP target could be achieved?
Think Tripati will
No.
answer, but as far as I am concerned, these drugs, when the blood pressure is not coming under, as you mentioned, is elderly in 60 and above, we usually consider isolated systolic hypertension as a possibility there existing. And of course, we have to use ACE inhibitors or drugs, and if the patient has not responded, add up a beta blocker and add up a diuretic. And there is no role for the combination of ACE and ARB drugs in these elderly people particularly. And there are some newer drugs are available and newer modalities. Definitely these are the patients who may have atherosclerotic renal artery stenosis. We should evaluate them, okay, to find out there is any significant renal artery stenosis also. Apart from that, the usual cocktail that we use for ischemic heart disease prevention, that is statins and aspirin, may have to be considered. Tripathi, you would like to add anything here?
Yeah, of course. I mean, it's it wouldn't be a good idea at all to give a suggestion on, on the phone without actually knowing the patient. You have to know a diabetic patient would have so many things going wrong, so many places at so many. One would like to look at his heart, see what is the cardiac function like. One would like to look at his peripheral, whether he has peripheral vascular disease or not, whether there is any possibility of him having renal artery stenosis, even unilateral, and all those things are there. And what is the creatinine, what is the potassium, and what is the fluid status, whether he's edematous or not. If he's edematous, it would be very easy to add a diuretic, especially if the creatinine is high. You can use a loop diuretic to ACE inhibitors. It would enhance the effect of ACE inhibitors. There are so many things that can be done. Um, Another thing I would like to add, as a nephrologist, we also use we especially where we encounter accelerated hypertension, high blood pressures, difficult to control blood pressures, we tend to look at the C-reactive protein as well. And if it is up on the upper side, or even if you don't look at it, that it's going to be on the ileal dust dysfunction, you give a statin. We give a statin straight away. We give statins to people who have proteinuria, because statins have pleiotropic effects over and above what they are doing to the cholesterol, LDL cholesterol or HDL cholesterol. We also give it to those people who have high CRP levels. We give it to those who have accelerated hypertension, and though of
Tripathi,
course in our CKD patients with advanced renal disease. Yes, sir.
Can I add a small comment here? Elderly persons,
Yes, please.
once in
Yeah.
a while, we should keep a pseudo hypertension also in mind. Particularly if they have a
Yes.
renal problem, they will have a thickened arteries because of the hypercalcemia, and that creates an elevated blood pressure.
Absolutely.
And again,
Absolutely.
it comes back to you to look at the calcium levels and make a decision.
Absolutely. We in fact, as nephrologists, on all CKD patients, we are particularly concerned about the calcium and phosphorus and the intact PTH levels. We are aware that if we are not taking care of the calcium and phosphorus, the product, we know the target. The product should be less than 55. If it is more than 55, then there would be vascular calcification. In fact, blood vessels become as hard as bones. When we do transplants, it is at that time, the blood vessels are being handled and you know exactly what is going on, and you are totally shocked as to the type of blood vessels you come across. Some of these patients, they have basically, hard pipe-like arteries, and the transplant surgeon sometimes is shaking his head and, telling us
some of the
what to do.
some of the rarities which we'll see. Paraj, if
Yeah.
there are no more questions, can we conclude the session?
Yes,
Yes, sir. I can see one last question from Dr. Ashish for today's session. He is asking, what is the role of ARNI in CKD patients?
Oh, very good question. What do you think, Tripathi? There is a role for ARNI drugs?
ARNI
Valsartan,
drugs, we, especially those who have systolic dysfunction, we have reserved, we keep it for that. For otherwise, I mean, if you have a situation where you have so-called cardiorenal syndrome, and you have systolic LV systolic dysfunction with concomitant renal dysfunction, ARNI obviously comes into play because they tend to work pretty well. I mean, they are apparently superior to ACE inhibitors as far as this particular situation is concerned, and we recognize the fact that if
Indian level ಅಲ್ಲಿ ಮಾತಾಡ್ತಾ ಇದ್ದಾರೆ. Okay.
we also
Tripathi,
recognize
I
the
take
fact.
care of you.
Yes, sir. Yes, sir.
Tripathi, thank you very much. I'll take
Okay,
you.
thank you.
Thank you
Wonderful.
so
Thank
much,
you,
sir,
sir.
for
Was a
your
pleasure,
precious
sir.
time.
Thank you.
Yeah, okay, thank you. Thank you for
Yeah,
the
it was
Okay,
really
sir.
was a good session, sir. Hope to see you again with different topics, sir. Till then, take care of yourself. We are closing here. Have a